Welcome to Vein and Lymphatic University. It is my pleasure, Lowell Kabnick, to introduce our speaker today, Sergio Gianesini, and he's going to be talking about Saphenous sparing strategy. We have the grandfather of Chiva here, Professor Claude Franceschi, and also a discussant, Matthieu Josnin. Sergio, the floor is yours.
Thank you so much, Lowell. Thank you so much, Victor, and thank you so much, Claude and Matthew, for joining. Of course, it's a pleasure to brainstorm together today on how we can bring the laws of physics in the operating room. Not by coincidence, this iconography that is looking at a toddler basically going against a big guy that could represent a big reflux. And of course, I like the very smart title that Lowell gave to this talk, workflow, because indeed we are going to talk about the flow in a Saphenous sparing topic. We are going to talk about hemodynamics laws, and of course we can make it very complicated, remembering or not remembering all those laws of physics that they taught us during the med school, or we can try to make it a little bit more simple and just remember that if we want to move an object from a point A to a point B, or back, as in a reflux, from a point B to a point A, all we need is a pressure gradient. And that's basically the concept of the Poiseuille law. So whenever we are talking about reflux, answering to the question of what is my workflow, or like brainstorming, looking at the patient, clearly is not just about detecting the reflux. It's pretty evident that there is a reflux when we see, for example, bulging veins. But it is understanding which is the point A and which is the point B, which is the leaking point and which is the re-entry point. So to make it again simple, in a simple model, we could say, for example, in an incompetence saphenofemoral junction, that the point A could be the incompetence saphenofemoral junction, indeed, with the point B being the re-entry perforating vein. Or it could be as a re-entry point along the incompetent tributary, the re-entry perforating vein that is there. So again, the important thing is understanding how we can subvert this gradient of pressure that is happening in between the superficial system and the deep system, where we understand clearly that there are different velocities that are leading then to an aspiration toward the deep venous system. So the question in Saphenous sparing approach, particularly when we are thinking together with friends and colleagues from countries where we need to treat the Saphenous trunk for having a reimbursability, is ablating or not ablating this Saphenous trunk. What could be eventually the advantage in doing that, and why we should do that? Well, I would say that morally, first of all, we should do that, considering that we know very well in the operating room the difference between a tortuous dilated pathological vein, like the one we see over here, and actually a vessel that is just straightforward. And when we touch it also in the operating room, we can perceive the difference between pathology and physiology. Of course, we have many different opportunities to treat these vessels, and they can be also quite appealing in terms of marketing. But in reality, whatever we do in terms of the different also innovative technique is usually ablating the vein. Either we cook it, we strip it, we glue it, and so on. So that's why at the end, very probably the recurrence rate remained quite the same of the previous papers. And indeed, here we have Albucaches of Cordoba was the first one describing the stripping procedure, because basically it's the same strategy that was proposed by Albucaches of Cordoba, simply ablating a vessel. And that's why actually in the guidelines, not recent one, but also like back in 2011, it was mentioned about the possibility of treating by hemodynamic approach, but of course, whenever we know how to do that, to make sure we are not making mistakes of removing or leaving parts that should be actually left, or to the contrary, removed. Cochrane looked at this along the years and actually demonstrated the possibility of having an improvement, but of course, always pointing out, as it often happens with the Cochrane, the lack of very solid data in randomized comparative trials. So it could work, but let's see a little bit how in this workflow that was requested in this topic and how complicated it might be at the end, because sometimes we're also scared about these very tough hemodynamic concepts. Again, if we want to make it quite simple, again, we have to stop the pressure gradient that is feeding, for example, an incompetence of the tributary from the saphenous trunk or of the incompetence of the saphenofemoral junction from the venous system, so that we can use the re-entry perforating veins that are taking the blood back into the deep venous system. And of course, Claude can explain this far better than me, as this is, I would say, the fundamentals of the Shiva strategy. That is, of course, a different concept than the technique. We discriminate between strategy and technique in this topic clearly. Another approach in terms of strategy can be the one of Asval, that is focusing on the concept of the reservoir. I would say far more similar to the ascending theory of the pathology, for which we remove the tributaries and we hopefully arrive there on time before the reflux really got into the saphenous trunk. If not in the Asval theory, there is of course the concept also of ablating the saphenous trunk if we are arriving, let's say, too late in the stage. But independently by Shiva and Asval, I would say that the important focus here is on hemodynamics, understanding that we cannot perform a pret-à-porter approach to the patients rather than haute couture. And this study is an example, in my opinion. This is an investigation we published years ago that was looking at the impact of the hemodynamics above the terminal bulb in the ilofemoral tract, showcasing that if there is an incompetence in this tract, we are going to have a 4.8 of odds ratio in terms of recurrence. This is very important if you think about that when we're talking about data in the literature, because we get the risk of comparing apples and oranges. Say that you want to see if radiofrequency is working better than laser, and you have two groups, and you don't specify the incompetence of the ilofemoral tract. You have actually one group that is at 5 times more the risk of developing a recurrence. So you might conclude that one device is better than the other, when in reality, simply the hemodynamic of one group was more favorable than the other. In this case, we still perform mini-invasive high tie because we feel that the pressure overload above the terminal bulb is demanding a little bit stronger closure that we obtain with the titanium clip in this publication, flash on the femoral, small incision, and the results were, of course, encouraging with a 5 years follow-up. Of course, there is an incision, so also in terms of the setup of the procedure is different from whatever office-based procedure. But again, the focus, I think, here today is on hemodynamics, for which, when we're talking about re-entry perforating veins, we should not consider that so simple as an anatomical and physiological tract, because we are used to consider these vessels as incompetent when we have an outward diastolic flow lasting more than 0.5 or 0.35 according to the publication sequence. But in reality, these vessels are there to compensate the pressure in the different compartments of the leg, for which I really care about this publication we did years ago, but that remains very important in the message. This is a study we did with a QDP technology, with a quality Doppler profile. So basically, it's a multi-gate analysis. So rather than having just one sample volume, you're having 256 sample volumes that are giving you not just the outward diastolic flow, but the net flow, so the direction of the net flow along all the perforating vein. And as you can see, whenever you have an outward diastolic flow lasting more than 0.5 seconds, in reality, the sensitivity of detecting a net outward flow is pretty low. It's at 13.9%. Summing up, this means that, again, if we have a 0.5 outward diastolic flow, the chances that the net flow is really outward are very low. To the contrary, if it is less than 0.5, the chances are high. So the clinical message here is just don't rely on the outward diastolic flow, just look at the net flow before deciding what to do. Hemodynamic approach, or like saphenous sparing approaches, can be also a hybrid. We published about the small saphenous vein. Sometimes it can be tricky at the saphenopopliteal junction. And so to get a closer to the flash ligation concept with a small incision combining sclerotherapy on the proximal stump, then twisting to keep it there, and sparing the rest of the small saphenous vein. So if you're interested in these kind of approaches in the operating room, you can find a dedicated publication that is highlighting the benefit in terms of reduced paresthesia after the procedure, that of course remains quite a concern also with the most modern endovenous procedures. But of course, endovenous is the way in this time of phlebology, and we are even talking now about extracorporeal, so we can discuss if you want to during the discussion time about that. We published in this sense the technical evolution of using segmental ablation, using lasers and radiofrequency. You see 6 centimeter because the study was done using radiofrequency thermocouples of 3 centimeters, so for uniformity with the lasers and radiofrequency, showcasing the feasibility of this and showcasing no significant differences in radiofrequency versus lasers. Of course, these are short follow-ups, and we should always remember that before 3 years at least, there is not that much meaning in giving follow-ups. In conclusion, to answer to the original question of the workflow, to tell you how I think, if there is an ilofemoral tract incompetence, I usually prefer to have a mini-invasive high tie. If there is a competence there, I go for the terminal valve. We usually look at the femoral side of the terminal valve, not at the saphenofemoral arch, because we know from Capelli investigation that we have a high chances of having an incompetent arch, but a competent terminal valve. So if the terminal valve is really incompetent at 2 different maneuvers, then we go for an incompetence diagnosis, and then we do, for example, a laser or radiofrequency. Can also be eventually glued, but in a segmental way. Then in the other cases, we just aim at the tributaries. It can be a flash ligation, it can be a sclero, depends, of course, on where we are, because, of course, sometimes we don't have the sterile setting of an operating room or like of an office surgical-based procedure. And of course, if we want to have the reaching of places like the pelvic escape points, then of course it will be a sclera. So I like to conclude quoting one of the giants of the previous UAP, now WAP, that is Glauco Bassi. He was a great figure of the original founders of the UAP. And he was used to say that at that time, in the 60s, modern phlebologists should have known surgery, sclerotherapy, and compression. Clearly, we have to include the innovative devices nowadays. I would say that mini-invasive surgery still has a place in specific hemodynamic, even if rare cases. But at the center, you have to put strategy, because if you just look at these toys that they continue proposing to us in the playground of phlebology, of course, we are not really going to change those recurrence rates that we were mentioning before. So I finish with the same iconography. Strategy at the end is superior to the technique. The image is actually the tip of my laser fiber that is going out from a GSV that was treated but still spared. Concepts that you can find in the large documents we produced with BUIN along the years, 2019 about similarities and controversies in global guidelines, 2023 about evidence-based medicine against fake news, and now the big document we produce with the clinical governance of the Ministry of Health of Italy that is translated in English International Angiology Journal, and now in also many other languages. I look forward then for collaborating in data collection also in these aspects. If you want to join the V-Registry initiative, this is in different languages for future research that will be presented in this special room that is the Kenyatta International Convention Center, on purpose circular, to put at the center your vision and mission in phlebology and nymphology around the world. Thank you so much.
Thank you, Sergio, and thank you for what you do for the World Union of International Phlebology and Education. I'm now going to turn it over to Matthieu Josnin, and thank you for what you do for the French Phlebology Society again, teaching. And so questions and comments, and then I'll wrap up with Claude, the ultimate.
Yes, so thank you very much, Lowell, for this invitation. Thank you, Sergio. This is a very interesting presentation. I'm not an expert in hemodynamic. That's because in my practice, you know that what I learned in university is very clear, is that if a varicose vein is ill, we have to ablate this varicose vein. You know, the reflection is very short. That's why it's so short, and I think it's not a good thing. Is that is why, because I think that techniques like, for example, Shiva as well are very good techniques in my mind. But these techniques, and it's very, very good to have Claude here, because Claude is a very big expert in the world. These techniques remains highly surgeon dependent and requires a high level of expertise, because for sure. And I think that there are several criteria to be met regarding Shiva procedure. I speak about Shiva. And of course, there are criteria to be met for thermal ablation. You speak about this, and very good. And I think it's very important. I think that we must not forget that preserving venous function in cases, for example, of bypass surgery for coronary arteries remains important for patients who have risk factor, and we have to think about for this patient before treating them, and perhaps also I think we have perhaps to revise our guidelines, and perhaps to and not thinking solely on SIP classification. Perhaps we have to say that before, I don't know, below 5 millimeters, we have not to treat great saphenous vein. I don't know. But I think that what is important is to perhaps to think about preserve the great saphenous vein for some type of patient, because I think it's the truth. In my country, it's the truth, sorry, but if I take the Shiva treatment, it's not widespread like before. Why? Because I think that the expertise is not the same as before. And now we have a reimbursement for laser, for radiofrequency, and it's all everyday practice. So I want to ask you that can it be a reality to learn again in the university hemodynamic to the student, because phlebology, as you know, is not a real discipline. Is not very. It's not a specialty. We say this every day, and so perhaps to learn this to the student, and to learn phlebology as a discipline with hemodynamics parameter, and perhaps to make students with real skills about this, and perhaps to make them as better surgeons, better interventional doctors, to practice better the choice between a Shivan as well and thermal ablation, because that's the real problem, I think, because it's very easy to perform laser, radiofrequency, or sclerotherapy, but I think it's more difficult to practice a good Shiva. Practice a Shiva, it's not difficult. It's not difficult. You know to perform a phlebectomy, you know to perform a Shiva, but to perform a good Shiva, it's too difficult. And when we look at the studies, the problem is that the results are not so good, because there is a surgeon dependency. It is the real problem in my mind. That's why the results are not so good. Perhaps Claude will disagree with me, but it's my mind. It's the reality. So that's my question. Perhaps I don't know. It's not a real question, but this is anything.
Sergio?
Matthew, thank you so much for your insights, and also for what you do in terms of education. So I will actually revert immediately a question to you. With all the people you meet, with the great work you have done with the French Society of Phlebology, how many of them are asking you to learn ultrasound rather than coming to the operating room to learn some eco-guided procedure just to stick a needle or like use a new device? I think, as always, with so close friendships that we have, let's agree to disagree. I kindly disagree on the fact that Shiva has to be surgically oriented only. Actually, to the opposite, it should be ultrasound experts oriented. So I think that the great job you are doing in terms of education is focusing, Matthew, with SFP, with the French Society of Phlebology, the attention toward the vascular medicine and the learning of the ultrasound, because the real difficulty in Shiva is understanding when to do it and how to do it properly. I was born and raised as a 100% Shiva guy, and I say this with all the full respect of Claude that I admire so much, but now I'm 75% a Shiva guy because one of the major topic here is also the anatomical feasibility of Shiva. You asked before, like when to eventually decide to ablate or not. So for example, there are nice publications showing that if you don't have chronic venous disease, in 13% of cases, you have a short stump of GSV, then it's popping up then with a tributary. But if you have varicose veins, they found up to 27% of patients with a short stump and a tributary that is popping up. So in those cases, when you have just a few centimeters of GSV, I don't know if I should really spare the GSV, and actually I don't do that. One other
Sergio,
thing that
I want to get in here. We've got 10 minutes. And a
Sure.
question that I have, it's not really a question, it's a statement. In the US, Shiva is not really recognized. And I think you've touched on a point which is really informational, and that's the hemodynamics. And the difficulty of learning hemodynamics is learning really good, sophisticated duplex ultrasound. And I think that's the linchpin here in the US. A lot of physicians that practice phlebology here do not do their own ultrasound. They may do it at the time of the procedure, which is limited, but they don't do it. So I think the idea of bringing back hemodynamics and looking at this is really important. Whether we continue on with the Shiva methodology, I think to be determined. But I think as Claude's going to say, the idea is very hemodynamically sound. The publications, and obviously I went to yours to begin with in 2014 to understand everything, and then I read Claude's book, so I understand it all. I'm going to turn it over to Claude, but I do have a question for him. Has anybody looked at the vein post-Shiva in terms of pathology? Has it restored to normal venous pathology? Claude, I'm going to let you comment and take the show. Thank you.
Thank you, Lowell. Well, okay, it's since now more than 30 years, we are still steady at the same place. There is no progress because all the basics of hemodynamics were born at this moment. But it is not a difficult hemodynamic. It is just hemodynamic. And to understand hemodynamic, you just have to study it. If you don't study it, you can't understand it. And most vascular surgeons and phlebologists didn't study. So if you don't study, you can't understand. And if you don't understand at all, you change from phlebology to dermatology. Because I am a patient now, what I am waiting for you, surgeons, phlebologists, I am waiting for you to give me the best of your specialty because I am the patient. And you are supposed to know the best, to treat for the best. And you are supposed to tell me that if you ablate my saphenous vein, if tomorrow I need it for a bypass to save more or less my leg or my life, why don't you tell me that? This is a medical legal problem, one. And the second one, why we don't know? It's easy, because it is not taught. For example, in my country, I give conference and courses in every country all over the world, except in France. Because French phlebologists and so on, no, they say it's too difficult. But if it's too difficult, you change. Stop being phleboligist, because people who go to you and ask you to be treated by you believe that you are experts, but you are not. And this quite easy. And my experience is now all over the world, thousands of Shiva are proceeded, and it works very well. And it's no more a problem for who knows. You have wrote so many articles we have made so many studies, trials, all over the world, you know. For example, for Matthieu Josnin, he is president or not, they never invited me to to explain them. Why? You know, I am not thumb. I am not mad enough. I am okay. I have all my brain sane. Why not? Because that's funny. And the problem for me is a problem, scientific problem of scientific honesty and legal honesty with the patient. That's fundamental. And
Claude,
for
thank you very
example,
much. I
we have
appreciate what you're saying. Is there anything new in Chiva strategy, or is it the same?
strategy, you know,
Sergio, you can answer.
yeah. The basic is, you know, when Shiva comes from understanding the pathophysiology of the venous system by the hemodynamic changes or not. And so I described the different compartments, I described the shunts, I described the reentry and everything about it. And from this, you know, you don't change it because when you have the law of gravity, you know that if you drop something, it falls, you know? And that's the same thing. You have the if you follow at the moment, for example, for the disconnection, you have made progresses. I mean, disconnection, if it ligations, for example, for the saphenous junction, now we have less than 1% of recanalizations with
Thank you, Claude.
all
I've got
ligation.
for time period.
Yeah,
I thank you very much for helping us on that. I'm going
it
to
was
let
a pleasure.
Sergio finish and comments.
Thank you, Lowell, because I think it's very important what you asked in terms of data. We published the normalization of the biomarkers of inflammation on Cytokine Journal. So IP10, RANTES, and PDGF, so platelet red growth factor, are normalized in the same patients after you go collecting the blood, both locally and systemically. So this is the ultimate proof that the inflammatory trigger of reflux is reverted, even if you have a retrograde flow, because as I showed, the flow goes down in a Shiva after the procedures going into the reentry perforating vein. So I think this is important. I think it's important in a very great opportunity like the one you gave us today to talk about Shiva and hemodynamics, to suggest to the colleagues to think hemodynamically. It's not so much, I think, for saving for a bypass or such that can be quite a rare event, but maybe we are over-treating our patients. And also with the new technologies, we can maybe apply hemodynamics to spare as much as we can of the Saphenous system.
Yes, for Lowell, just 1 second to tell you that we have about bypasses. The Saphenous vein was studied after Shiva with histology by Massimo Capelli, by Roberto Del Frate, and the vein is normal. Secondly, there is a lab in Lyon, in France. They buy stripped saphenous veins to sell them to bypass patients.
Thank you.
They say,
I have 2 minutes left, and I want to tell everybody, think hemodynamics. I think it's really important to understand it. And with the hemodynamics, you really need to grab an ultrasound probe and look at what's going on. And I thank Claude for making us in terms of stimulating us. Sergio, thank you for making it easy to understand. Your article is what tipped me off in terms of making it easy. Chiva for dummies like me. I think it was really important. Matthieu, thank you for your comments and questions. Malik Aminu has said something on the chat. I think it's important to read. And next week, we have complications of venous stenting. Now that it happened, what do you do? Thomas Wakefield will be our guest host. Professor Dagansi will be the speaker. Jose Almeida and Stephen Abramowitz will be the discussants. So next week, same time. Thank you, everybody. Have a good rest of your day.
Bye.
Thank you. See you.
Good one.
Bye-bye.
Bye.
Thank you.
Thank you. Bye.
Bye.
Bye. Bye.